Thank you for allowing us to present our work. Peroral endoscopic myotomy, also known as POEM, is an endoscopic single-stage treatment for achalasia and other esophageal motility disorders. It has been shown to be safe and equally efficacious when compared to Heller myotomy, which is the gold standard surgical treatment for achalasia prior to the advent of POEM. However, multiple studies have shown that rates of reflux are higher after POEM than they are after laparoscopic Heller myotomy. This is likely due to the fact that no anti-reflux fundoplication is performed after POEM like it is after Heller myotomy. The endoluminal function lumen imaging probe, also known as EndoFLIP or FLIP, is a balloon-based catheter that can be used to measure the diameter and intraluminal pressure of the esophagus, and specifically the lower esophageal sphincter. The FLIP technology is based on impedance planimetry, in which pressure transducers are used to estimate the cross-sectional area and distensibility of the LES. FLIP can be used in the operating room or during EGD. The aim of the present study was to determine whether FLIP measurements, which are collected intraoperatively before and after myotomy during POEM, can be used to predict the development of esophagitis postoperatively. We hypothesize that patients with higher cross-sectional area or higher post-myotomy distensibility will be more likely to develop reflux postoperatively. We conducted a retrospective review of a prospectively maintained quality database and analyzed all patients who underwent POEM between 2012 and 2019 and subsequently underwent EGD. Responses on patient-reported quality of life surveys, specifically the GERD, HRQL, and RSI, which we distribute both pre- and post-operatively, were also analyzed. We used Wilcoxon's rank sum and Fisher's exact tests to make comparisons between our groups. Data from 43 patients were included in the analysis. We found that 58.1% of patients at postoperative EGD had evidence of reflux. The severity of reflux was obtained from EGD reports and stratified using the Los Angeles grading system. There was variation in the severity of reflux, but grade C, which is moderate to severe reflux, was most common, with 11 patients receiving that grade. In terms of patient demographics, there were generally no statistically significant differences between groups, aside from a preoperative diagnosis of COPD, which was more common in patients who did not go on to develop esophagitis. Otherwise, there was no difference in age, BMI, indication for POEM, or rates of preoperative esophagitis, although preoperative esophagitis was more common in patients who went on to develop esophagitis after POEM. There were differences in operative characteristics, and patients who did not develop esophagitis after POEM had a longer length of myotomy and were more likely to suffer an intraoperative complication. When considering the FLIP results, we analyzed the pre-myotomy and post-myotomy measurements, as well as the change in measurements. The measurements that we were interested in were the D-min, or minimum diameter, the CSA, or cross-sectional area, and the DI, the distensibility index. There were no significant differences between the groups, but patients who went on to develop esophagitis trended toward higher D-min, CSA, and DI measurements, both pre- and post-myotomy, and also trended toward higher changes in those measurements. We attempted to determine cutoff measurements for both cross-sectional area and distensibility and found that patients with a final DI of greater than or equal to 2.7 or a final CSA greater than or equal to 83 were significantly more likely to go on to develop esophagitis on postoperative EGD. Both cutoffs were statistically significant. When we analyzed the health-related quality of life measurements, however, we found no statistically significant differences in patient responses when comparing patients who had objective evidence of reflux on EGD, neither preoperatively nor up to 2 years postoperatively. This study has a number of limitations. First, the data presented is only a subset of the total number of patients who have undergone POEM at our institution. However, at this point, less than 50% of patients have returned for postoperative EGD or pH testing, but we are making a concerted effort to get these patients back. Due to this reason, we may be overestimating the incidence of post-POEM reflux because patients who have symptoms are more likely to follow up and get EGD. Secondly, although previous studies have shown that high-grade esophagitis is strongly correlated with GERD, pH testing is a gold standard for diagnosing GERD. Due to our small sample size, we had significant variation in the data and large standard deviations. Future studies with a larger sample size will likely yield more accurate results. Finally, this was a retrospective study and there is a possibility of selection bias. In conclusion, we found that 58.1% of patients who underwent EGD after POEM in our cohort were found to have reflux esophagitis on postoperative EGD. We found no correlation between development of esophagitis and patients' responses on reflux-related quality of life questionnaires. Finally, we showed that FLIP measurements can be used to predict which patients will go on to develop esophagitis, and further studies are required to determine whether they can be used intraoperatively to prevent reflux. Thank you.